Good afternoon. My name is Joseph Ravenel, and I'm an Associate Professor of Population Health and Medicine and Associate Dean for Diversity and Inclusion at NYU School of Medicine. I'm also pleased to be a member of the National Colorectal Cancer Roundtable Steering Committee. Thank you, everyone, for taking the time to join us this afternoon. We've had a lot of interest in this topic and really appreciate your time. We know that nationwide, 1 in 3 adults between 50 and 75 years old are not getting screening tests as recommended, but among underserved populations, screening rates are often much lower. This is why it's especially important for us to understand and address the unique barriers to screening in these communities. The purpose of today's webinar is to move beyond describing the challenges of reaching the underserved to showcasing innovative solutions. We'll take a look at 3 examples: how one local health department teamed up with an academic medical center to invest in community engagement. Second, how systems change can increase colorectal cancer screening in a multi-ethnic community. And third, we'll look at how partnering with emergency departments can help reach rural residents who don't have a primary care provider. During the webinar, we'll hear from Dr. Karen Kim, Professor of Medicine and Dean of Faculty Affairs and Associate Director of Cancer Disparities at the University of Chicago Medicine Comprehensive Cancer Center. Dr. Kim also serves on the National Colorectal Cancer Roundtable Steering Committee. And then we'll hear from, after Dr. Kim, we'll hear from Dr. Jenna Hatcher, who's the Director of Diversity and Inclusion at the University of Kentucky College of Nursing. I'll be sharing my own work at the NYU School of Medicine. Before we begin, I'd like to share a couple of housekeeping details before we get started. First, we are recording today's webinar. The replay and speaker slides will be shared with all of you within a few days. Please feel free to share with your colleagues that were not able to join us today. Also, because of the large number of participants, all participants are muted on today's webinar. Having said that, we still want to make sure you get what you need out of the webinar. So we encourage you to ask questions by submitting them through the webinar Q&A function. We will have time for questions after the presentations, and we'll answer as many as we can. And we'll also be emailing around responses to any questions we don't have time to get to. You can also email us specific questions afterwards. And finally, we are always trying to improve our webinars, so we're asking for your help in evaluating the webinar. You'll be receiving an email with a survey link, so please help us out by taking a few minutes to provide feedback. We take this advice very seriously and are always trying to improve. Before we get started, I'd like to share a tip on how to find resources to support your work in underserved communities. Last fall, the National Colorectal Cancer Roundtable launched a new resource center that makes it easier for you to find evidence-based innovations and tools to increase colorectal cancer screening in a range of settings and populations. You can use the filters to search by setting, target audience, intervention type, and more, which makes it easy to find tools tailored to working in specific populations. For instance, you may find the National Colorectal Cancer Roundtable's guides on conducting culturally competent outreach to unscreened Hispanic and Latino and Asian American communities. Users can also submit their own resources. It truly is a one-stop shop to find valuable tools to help you with your work. So I encourage you to check it out and to visit often. So with that, I will start by sharing some of my own work. So today I'm going to talk about a partnership between an academic medical center and local health departments, and share some of my experience in New York City. So colorectal cancer affects different populations differently. There are definitely disparities that unfortunately have been long-standing and continue to exist. And Black men in particular have the highest incidence and death rate from colorectal cancer, in large measure due to lack of timely screening. There are a couple of other contributing factors that are at play here when we think about disparities in colorectal cancer mortality. One, as I mentioned, Black men are less likely to have screening colonoscopy in a timely way. And we know specifically in New York City that Black men are less likely to have a screening colonoscopy before the age of 65. And that, as you know, 65 coincides very much with the age at which people are covered for Medicare. So access is probably part of the challenge. But we also know that Blacks are less likely to have diagnostic resolution after an abnormal screening test. And so these two factors are areas where patient navigation can have a significant role. So when we think about the process of colorectal cancer screening, it's not the most straightforward process, and it's certainly not an easy one, even for those who are well educated and who are familiar with healthcare systems. So if we start here at the population of people who need to be screened, in order for them to actually complete screening, they usually have to interface with the healthcare system, often in the form of visiting a primary care doctor. Then the doctor has to actually make a recommendation for colon cancer screening, and then the patients have to actually make the appointment and find an escort, complete the prep, and ultimately show up for the colon cancer screening test. And there can be barriers at each step of this process, but we know from other cancers and from other disease conditions that patient navigation can be key in kind of closing the loop and helping patients to complete screening in a timely way. This is particularly important in Black men who are less likely to have a primary care doctor for a number of reasons, including access, but also attitudinal barriers, and an important issue of medical mistrust. This is evidence from a study, a population-based study done in Dallas, Texas, where we looked at 6,000 Black and white men and women, and found that among older Black men that they were less likely to have a primary care doctor. So thinking about all of those factors, how can we reach Black men if not through primary care doctors' offices? And we think a lot about place-based interventions for reaching populations that are less engaged with the primary healthcare system. And so this here is a picture of a barbershop here in New York City, Denny Moe's Superstar Barbershop, which is actually where I have gone for the last 9 years to get my hair cut and for a number of other reasons. But the barbershop is a place where we can actually bring healthcare interventions to where people actually spend most of their time, which turns out is not in the healthcare setting. So why are barbershops potentially an important place for healthcare providers to partner with? One is the barbershop is an incredibly important cultural institution that has a long-standing tradition of being a safe haven for Black men. It's affectionately known as the Black Man's Country Club. It's a relaxed, non-medical atmosphere where men can go up to 4 times per month, sometimes more. There's also a tradition of barber surgeons where actually in barber schools and colleges currently, there is a requirement that they participate in healthcare curricula. And so this idea of aligning healthcare with barbering is something that is not new to the barbering profession. And then within the African American community, barbers are seen as key opinion leaders. And I've been told by my barber and others that it's not uncommon for customers in barbershops to trust their barbers more than they trust their doctors. And so we think that this is potentially a very effective and sustainable medium for reaching Black men. The barbershop is also an attractive place to think about doing healthcare interventions when we think about the social determinants of health. So if we look to the far right of the screen, this here is the health outcomes that we're trying to impact. So in this case, colon cancer screening. But all of these other factors that are kind of upstream have an impact on achieving those health outcomes. So here we have the more proximal determinants, kind of what we call meso determinants, and here we have more distal or macro determinants. So the macro determinants are societal factors such as racism, cultural, political power, socioeconomic status, historical context, and the legal system that we tend to have less control over as healthcare providers and researchers, but these are obviously very important factors that can determine whether or not people engage in certain health behaviors. Here we have more mid-level determinants such as stressors and survival needs, medical care, support systems, and psychological resources. And then here we have the actual health behaviors that we're trying to change, such as colon cancer screening, going to visit primary care doctors, and ultimately we want to reduce the incidence of colon cancer and actually eliminate the disparities that we see. So the barbershop actually gives us an opportunity to actually utilize this social determinants of health framework. So looking at our model of how colorectal cancer screening happens and kind of superimposing that on the barbershop, one of the questions that we wanted to address is how can we identify unscreened men and navigate them from the community? The patient navigation literature largely focuses on navigating people from the primary care doctor's office to the colonoscopy suite. But we know that there are many people who are not actively engaged in primary care, and so we wanted to think about how can we actually go to a community and find men where they are and ultimately get them to screening. So the hope is that we will, the hope was that we would be able to reach men in barbershops, help them and assist them with connecting with the healthcare system and ultimately getting a referral to screening, and then to help to navigate them to actually complete screening. And that was really the basis for the NYU Men's Health Initiative, which was a compilation of projects that really focused on improving men's health regarding colorectal cancer and cardiovascular disease. So this is a schematic of what was involved in our initiative. It was really three NIH and CDC funded studies. One was based in churches, another was based in barbershops, where we put patient navigators actually in barbershops to identify unscreened men and actually connect them to where they could be screened for what they could afford, and to actually team up with them to help them in whatever way address barriers to screening and ultimately complete colonoscopy or other screening modalities. And we were able to get some funding from the CDC to help us compare the efficacy of these interventions in barbershops compared to those in churches. For the purposes of today's talk, I'm just going to focus on the barbershop aspect of our initiative. So we tested culturally targeted patient navigation, which included multiple sessions. The first session, where we met the men in the barbershops, focused mainly on education around colorectal cancer and actually making the men more aware of the need for screening. We tried to elicit barriers that were preventing them from being screened. But we also wanted to assess where they were on the stages of change spectrum, and if they weren't ready to make the appointment for screening, part of our job was to help move them along the readiness spectrum. And in subsequent sessions, we wanted to revisit any remaining barriers. We wanted to materially assist with scheduling, help them find the appropriate screening facility as well as the appropriate screening modality, and then to just provide support all the way through to completion of the screening test, but also to help with follow-up for any abnormal test. This is a map of the more than 200 sites that we partnered with. As you can see, we were all throughout New York City in all 5 boroughs, including Staten Island over here. We, in all, in the barbershops, were able to recruit over 700 men who were on average 55 years old. This is the breakdown of the educational level. For the most part, they were born here in the U.S., and 25% were married, which was less than we expected to find. We also found a fair amount of economic disadvantage, with only 21% being employed for wages, and an annual household income of $70,000 per year. And we found a very heavy burden of smoking. So with our intervention of placing patient navigators in barbershops, we were able to realize a screening rate of 36% among men who were randomized to the patient navigation arm. Again, at the beginning of the study, all of the men were unscreened. So 36% of the men that were randomized to the patient navigation arm, we were able to successfully assist in completing screening within a 6-month period, compared to those who were in the usual care arm who just got referrals from their doctors. And these numbers are fairly consistent with other literature that focuses on similar populations. So the take-home points for this study are that the patients who received the patient navigation intervention were more than twice as likely to get screened as those who just got usual care, usual referral from their doctors. And the intervention, importantly, was equally effective for those with no health insurance and those also with low health literacy. So navigation was able to overcome many of the traditional barriers that stand in the way of vulnerable populations getting screened. So we were very happy to publish our findings in the American Journal of Public Health recently, and as a result of some of the success that we had, we recently began partnering with the New York City Department of Health and Mental Health, who was very instrumental actually in training some of our patient navigators for the study. So we now have a program called Communities Partnering in Navigation in New York City, and we really do try to leverage the success of our barbershop-based program. And so our program is, the Communities Partnering Program is funded by the New York City Department of Health and Mental Health, and it's a 3-year project that enables us to expand the work of the Men's Health Initiative, and our goal is to refer 10,000 medically underserved individuals to colorectal cancer screening, but it also enables us to expand to breast cancer screening and to try to increase screening rates for breast cancer as well. And this program, importantly, funds a total of 7 navigators to help us get out into the community, but also to work with community health centers to try to reach those people who are unscreened. So I'd like to thank the Men's Health Initiative team, the 200-plus community partners, the 7,000-plus participants in the initiative, the very generous funding that we have received, and certainly our partners at the New York City Department of Health and Mental Health. So with that, I'm going to pass the baton to Dr. Karen Kim, and we'll be happy to take questions at the end.
Thank you, Dr. Ravenel. That was great. Again, I'm Karen Kim and really excited to be presenting today. And I wanted to take a little bit of a different approach. I'm going to be talking about using health information technology to increase colon cancer screening, to really think about how we might make a system-wide platform to help vulnerable populations. So a little bit about, I'm from Chicago, and so I'm going to present data that's very local data, but thinking about the burden of colorectal cancer and a very unnecessary burden. Every hour, about 16 people are diagnosed and die from colon cancer. And every minute, 44 people are not being screened nationwide. And in Illinois, that amounts to about 2 million people, which is really unacceptable. And when you think about where Illinois fits across the entire United States, we're among the lowest quartile, and our screening rates range about 50%. And if you think about really the diverse population in Chicago, we have about 37% are African American, 27% are Hispanic, 6% are Asian. We really need to do better in our state. And so we got funding from the CDC, as I'm sure many of you on the phone have also gotten funding, as part of the colorectal cancer prevention program. And we brought this into the University of Chicago, and the university is located on Chicago's south side. And really 7 of the 8 poorest communities in Chicago are located right in our catchment area. And so we're really excited to be able to think about ways to increase screening for our populations. And we've had a fair amount of success. We've basically partnered with local federally qualified health centers, and you can see that we've had at the university, our screening rate, we didn't move the bar too much. It's stuck at 66%, but at FQHC-A, we've increased the screening rates to 51%. At FQHC-B, we've increased rates to 49%. And at Clinic C, we are still trying to get data out of their electronic medical records. So we know that implementing evidence-based interventions, which is what we've been doing, works. But really also realize that we noticed some interesting patterns. This is looking at BRFIS data for colorectal cancer screening with the question of, have you ever been tested? And you can see the darker colors, darker red color means that higher rates of being tested, and the yellow color shows less testing. And I'm going to point out Cook County, which is in that upper right-hand corner, which is kind of in the middle, around the 50 to 60% range. And what is interesting is that if you look at hospital sizes across the state of Illinois, where there was really kind of medium-range screening, you can see that there's a lot of resources. And again, just to remind us, these are GI offices and federally qualified health centers and lookalikes. So you can see there's a very large concentration in Cook County, which is where Chicago is. And I think if I remind us where the screening rates are in a blown-up map, Cook County is at about 60%. But again, I want to remind you that if you look at Cook County based on resources, you can see that compared to the other counties where screening rates may be higher, it's really unacceptable that we have all of these resources located in Cook County where Chicago is, and yet our screening rates are not at the top of the list. And so what are the key health system barriers that need to be addressed to increase screening and optimize quality services? Certainly at the provider level, we know that often providers don't communicate with each other, particularly between primary care and specialty care. And this inadequate and inefficient communication has been shown to really cause a lot of problems. Over 50% of referring providers have really no communication with their specialists. 45% of specialists don't send information back to the referring physicians, and 25% of information for specialists often arrive too late, where you cannot make good medical decisions. Another point is at the patient level, we know that if there's no point of service specialty scheduling, that 50% of referrals will fail to result in a procedure. That is, if you can't get your patient on a schedule while they're with you, they often don't go ahead and get scheduled. And we know that hospitals also have unfilled capacity when it comes to colon cancer screening. About 24% of all available endoscopy slots are never filled. And so there's a cost effectiveness implication as well. This is just an example of an average day at the University of Chicago, and you can see that everywhere you see a red arrow is a slot that was not filled. And so if you had on average 10 cases per room per day at the university, we had only 20 slots filled when we should have had 4. We had 10 slots filled when we should have had 20. So again, missed opportunities. And again, from a societal standpoint, what are some of the system barriers that result in decreased screening? We know there's many, and from who pays the price, society does with colon cancer. And here's the big problem. A 1-year delay in screening can increase the cancer risk twofold. That is, if you get a FIT test or a stool-based screening, which happens in a lot of our federally qualified health centers, only 47% go on to have a complete diagnostic exam, and that is being able to look for polyps and hopefully remove them before they become cancer. And so this is a real problem. And so when I think about the ability to link patients to care, I think that the system is really broken. And maybe it's not broken, but it was just built that way, where we really are not able to communicate well across unintegrated systems. And so one of our local solutions, we found out from our providers in primary care clinics that they actually were disincentivized to get screening done using FIT testing, because when the FIT tests were positive, they had no place to send their patients. And in our safety net system in Illinois, we have one big safety net system. There was over an 18-month wait for patients to go on to get screened. And so primary care providers weren't sure that they should even start screening because they didn't know what to do with the positive results. And so we built a cloud-based portal which is HIPAA compliant in order to link patients from primary care clinics to specialty services. And this is kind of how it works. We asked hospitals to allocate slots for patients. That was part of their community benefit and just goodwill to help fill their capacity. And we had patients scheduled in their primary care clinic offices by going into a portal, kind of like an open table portal, before the patients leave clinic, because we know that 50% of those patients who leave the clinic without an assigned appointment will not go on to have their complete procedure. And then the patient completes the procedure, which reduces their risk for colon cancer, and then the clinic receives the results and quality benchmarks back in the portal, which closes the loop, which we thought was a really nice system to help with capacity. So the concept was very simple. Patients need a colonoscopy. Hospitals have many unfilled slots, and they donate the slots, and we get our patients to be able to get their procedures. We piloted this with several hospitals that donate slots, the University of Chicago, Swedish Covenant Hospital, and Rush Medical Center, and they were each linked to an FQHC. And to date, we screened our first 25 patients that have no insurance that were FIT positive, and we found about 40% with polyps. So we think that this may be an interesting local ability to link patients to care who are in need of specialty services. And this is my team. Thank you. I'm going to go ahead and pass the baton on to Dr. Jenna Hatcher, and we will be taking questions at the end of the conference.
Okay. Hi, I'm Jenna Hatcher at the University of Kentucky, and I'm the Director of Diversity and Inclusivity here in the College of Nursing. I am going to be talking about promoting colorectal cancer screening in rural emergency departments and a project that we did here in rural Appalachia. So first of all, I'm going to start with why I chose the emergency department to do this type of study, colorectal study. There are a lot of people who visit the emergency department, over 100 million emergency department visits per year in the U.S. 1 in 5 Americans visit at least once a year. And we know that the people who are unlikely to be screened for colorectal cancer are also unlikely or very likely to visit the emergency department, including African Americans, other minorities, and people who are socioeconomically challenged, because as income decreases, the likelihood of visiting an ED increases. We also use the ED because people who are visiting there for non-urgent care or using it as their medical home are often there for 3 to 6 hours because they're there for non-urgent care and it's an emergency department. And finally, we think that we have what we call a teachable moment. We think that because we are in the emergency department, people are thinking about their health, they have a heightened attention to health care, and they're more receptive to medical recommendations. So for those reasons, we decided to use an emergency department to conduct this screening promotion kind of work. We started in a more urban emergency department, but we decided to go into a rural emergency department for a number of reasons. First of all, because rural Appalachia has a higher incidence and mortality rate from colorectal cancer than people in other regions of the country. One of their primary barriers to screening is limited health care access, and so this results in not getting recommendations to be screened and low uptake of screening education. And so we thought we had an opportunity to maybe reach those folks who are not getting screened or getting recommendations or education in their primary physician's office, or those who don't have one. And also, more than half of all rural emergency department visits are low severity, which means they're non-urgent. So at least half of the folks sitting in those rural emergency departments are there for non-urgent care. And those cases largely occur during the day or during business hours when you're in a rural area. So we thought this is a great opportunity for us to go in and do some cancer promotion intervention. So we started by establishing the feasibility of doing this kind of work with a pilot study conducted several years ago. We've been doing this kind of work about 10 years, and we basically surveyed. We were doing promotion of mammography at that point, and we basically surveyed about 200 women, African-American women, who were visiting an academic medical center emergency department for non-urgent care. And we found that there was a high rate of folks who had never had a mammogram among that sample. More than half of them were out of compliance with the current guidelines at that time, and they were also very interested in talking to us and receiving an intervention while they waited. And so this resulted in the intervention we lovingly call SEEDS, which is Sisters Educated in Emergency Departments, and that's how we got started with this work that we continued in the rural setting. So the specific aims for the study that I'm going to talk about a little bit about today were to adapt and pilot that intervention and tailor it to promote colorectal cancer screening, in a rural Appalachian Kentucky emergency department. And specifically, we wanted to evaluate the feasibility of providing this type of service in an emergency department serving rural communities, and also to look at whether the intervention will be effective in combating those barriers, specific barriers that rural populations have to colorectal cancer screening, to increase their stage of readiness to screen, and to get them to engage in screening. And of course, the long-term goal is to try to eliminate this inequitable burden of colorectal cancer that is experienced in this population. So we started at first with just one emergency department, St. Clair Hospital, and the kind of beauty of using the rural emergency department is that the catchment area for those emergency departments is very, very large, unlike an urban emergency department that serves the area just surrounding it. So the first hospital we started with actually served 11 rural counties and over 160,000 persons. So it had a broad reach, and these were many of the people we're trying to reach, or the hardest to reach people. This was a 23-bed emergency department, and it served about 30,000 folks that came through there per year. We quickly expanded to another rural hospital, and that was the largest provider of care in southeastern Kentucky. So this intervention study covered both northeastern and southeastern Kentucky, which are both rural Appalachian areas. The second department, emergency department, was a 24-bed and saw somewhere around that 30K patients per year as well. So the way the intervention works is that we station a community health worker in an emergency department that just kind of floats in there. That person approaches people who appear to be eligible for the study, establishes eligibility, which I'll talk about in a second, randomizes them to control or intervention. Control groups get a brochure that you are likely to just pick up in any emergency department. People who are in the intervention get a motivational interview, and that's coupled with resource assistance that's specific to the area in which they live. So we canvassed that area, did some assessment of the area, and made sure that we could provide concrete resource assistance in addition to motivational interviewing. 1 week after the intervention, you get a follow-up call that reinforces what we've said while in the brief intervention you got in the emergency room, and then we follow up 3 and 6 months later to check on screening and how the barriers are being navigated. So here's the picture of how that intervention protocol works. And our eligibility criteria include being 50 years or older, having no history of colorectal cancer, no cognitive impairment, being English speaking, because that's what our community health workers were, and having have not had a screening for colorectal cancer according to the guidelines. So as I said, if you met those eligibilities criteria, you got the baseline interview, you were randomized, you got either intervention or control, and the follow-up phone call. And so here's this is a tiny slide that shows what the graphics in the study looked like. And here I'm showing you treatment versus control to show that there were no differences between the groups that were randomized. There were no significant differences. The average age was somewhere around 58. And most of these folks were white or Caucasian, as you would expect in rural Appalachian Kentucky, more females than males, and a variety of married and educational statuses. The income, as you'll note, about 50% of them make less in a family household than $40,000, and most of them do have insurance, as you would expect in this era, post-ACA era. And so I am reporting baseline results here. This study just wrapped up. We're still looking at the impact of the intervention, but more practically, we're interested in the feasibility of doing this type of work in an emergency department. So what we found at baseline was some of the reasons that people were not being screened in this population. And as we suspected, and the reason that we put this in an emergency department was those barriers are not necessarily those that result from resources. Now, about half of them say that it's the cost that's keeping them from being screened, despite the fact that they have insurance. But also about half of them talk about the fact that the barriers are fear of the test results and fear of pain of the screening. So we thought we were appropriately using motivational interviewing because that's the type of intervention that can help people overcome those specific barriers to colorectal cancer screening. We also found at baseline that we were in the right place because despite an average age of about 58, more than around 90% of our folks in treatment and control had never been screened for colorectal cancer. So they're at least about 8 years out from the recommended screening, and most of them had never been screened. So we concluded from at least our baseline look at this that the non-urgent emergency department users are not being screened regularly. We know that, in fact, they're not being screened at all. That using the emergency department to do this intervention is a feasible thing. We know this from having been in other emergency departments. We found confirmation for this in the rural setting as well. The flow of the intervention worked well within the emergency department. We found that community health workers are effective in this setting. We have a couple of papers that are out talking about the use of community health workers in this setting, and we found once again in the rural setting that it was indeed important to have a community member being the one delivering this intervention. And we found that there are both benefits and challenges to this type of work. And I'm going to discuss briefly the challenges that we found, first of all. When you're dealing with an emergency department population, they're transient, as one would expect, especially in urban areas, but also in rural areas. These folks are hard to follow up with. So what we found is we can do a great intervention. When they walk out of the emergency department, we may never speak to them again. We tried various things to overcome this. We tried getting different numbers from other people, a variety of things, but this is just a transient population, hard to follow up with, and that's one of the challenges to working with an emergency department population. There's also the challenge of fidelity to the protocol. We are talking about using community health workers and training them in a complicated technique like motivational interviewing, and so this means there needs to be very constant training with those community health workers that helps us to be sure that we're delivering our intervention in the same way across emergency departments. Contamination, as one might expect, people are frequent flyers in emergency departments. That means they come back again and again, and often you're seeing the same people, and you can get some contamination across the study, and we use a variety of methods to protect against that type of contamination. And also the privacy issue. Emergency departments struggle with privacy. It's one big giant room with everyone in it. We took some steps to make sure that we ensured the privacy of our protocol by having the emergency department give us private spaces in which to conduct our intervention, or we went into the participants' rooms if they were in the back to conduct the intervention. Despite those challenges, we feel that we had a lot of benefits. First of all, we're reaching what I call the high-hanging fruit. These are the hardest to reach people, people who have never been in research studies or have never had recommendations to be screened or are not in constant contact with the healthcare system. Most of their contact is non-urgent care, and it's in emergency departments where that specific need is met, and then they move out of the healthcare system, and they are not referred to primary care or other types of care. These are the people who, as we can see from those numbers, do not get screened. We believe that we were beneficial to the emergency department staff. They tend to like us a lot because people who have 6 hours to wait often can be bothersome and come to the desk again and again and again and ask you, is it my turn yet? So if we can even take up 15 or 20 minutes of their time, the staff really like us a lot. They actually usually have a list waiting. When we get there, these are the folks we think might be eligible to be in your study. Go to it. So we think that it helps actually with the flow in the emergency department as long as we don't involve the nurses and the other staff that works in that ER. One of the other benefits is the use of community health workers. This is an established benefit in terms of cancer promotion and colorectal cancer screening promotion. And so this is an integral part of this kind of work. And with that, I say I'm going to have questions because I am last, and I think that I will turn the baton back over to Joseph take those questions.
Great, thank you. Thank you so much, Dr. Hatcher and Dr. Kim, for those wonderful presentations. So now we'd like to take some time for questions. We have until the top of the hour, so we'll try to get through as many as possible. So if you have a question, please submit it in the chat box, and we'll take them one by one.
And we have gotten, hi, it's Mary Dorshank, the director of the roundtable, and we have gotten one question for you, Karen. How are you able to develop the partnerships with the hospitals to donate the slots?
Yeah, that's a great question. We thought it would be a big challenge, but actually we started with the hospital leadership. We usually met with the president of the hospital and explained the overall picture, and then we asked them to donate one colonoscopy per gastroenterologist every 6 months, which seemed like a very small ask, but it adds up because there's usually many gastroenterologists, and we got typically between 20 to 40 free colonoscopies a year.
Oh, fantastic.
All right.
Other questions?
I actually do see a couple of questions. One is addressed to me, asking how to start a barbershop initiative in the Southeast UA, in the Southeast USA, and this person is not associated with a college or university. What I would say is, to definitely start small. I think starting in just one barbershop, I think, is a way to just see how such a partnership can work, because barbershops can see lots of business even in one day, you can actually have quite an impact by just focusing on one barbershop. I would just say, just start by talking to the barbershop owner, and basically see what his or her perception of the needs are, and then take it from there.
Jenna, I believe this one is, oops, sorry. Go ahead, Joe.
Sorry, Mary, go.
Did you find motivational interviewing with the community health workers or the opinion influencers like the barbers was effective in alleviating any of the information avoidance due to fear of results or pain? Actually, that might be for you, Jenna.
Yes, we actually did find that motivational interviewing, especially by a community health worker, was effective in that way, because what you get is a combination of the technique of trying to understand someone's ambivalence coupled with a person who understands the community and also has had a colorectal cancer screening themselves, because we made sure that all the community health workers had indeed been screened. And so I think that combination did actually help with people who had real fear of the procedure or fear of the test results. So yes, I believe that motivational interviewing was impactful in this situation.
And Joe, they mentioned barbers in this intervention as well. Do you want to comment?
Yeah, so there's a question about how we got buy-in from the barbershop staff, and how we were able to bring up the topic. Realizing that colonoscopy in particular can be a sensitive topic for many men, we actually approach barbershops by talking about men's health in general, and we talked about both the problem of hypertension in Black men as well as colorectal cancer, and we actually offered a service to the shop of actually having health screenings, and kind of once we had men in our chair, who are willing to get their blood pressure measured, it was then much easier to broach the topic of cancer screening. And so what I would say as a general principle, coupling cancer screening with a topic that may be easier for people to talk about is something that we found as a very successful strategy.
Great. Karen, this one's for you. How did you determine the number of slots available for endoscopy appointments?
Actually, it was the hospital who was donating the procedures. They're the ones who helped us determine how many they would be willing to do, and it was based on how many uninsured patients we thought would be, how many uninsured patients there were per federally qualified health center that was linked with that specific hospital. So we knew that we would have the big enough capacity.
Okay, great. Karen, this might be for you. We want to take the burden off the public hospitals by paying for some of their patient colonoscopies done by and outside the facility. I believe this is Bridget Maddox, who's with a nonprofit in the California area. How can we go about it?
Yeah, I think that's a great idea. I don't think we can burden our public hospitals and federally qualified health centers more than they already are feeling burdened. And I do think that surgery centers and gastroenterologists and private hospitals are actually have been very generous in what we've found. Also because of the community benefit requirement for a lot of hospitals that receive federal funding, this fits well within what they can report as part of their charity care. And so this has been sort of a win-win for, I guess, a win-win-win for the patients and for the FQHCs as well as the hospitals.
Great. So this question is not directed to any one person, so maybe all three of you can comment. Do you have an established partnership with your institution's cancer center, if any? And if so, how did you envision this partnership with your cancer center to help advance the goals of improving colorectal cancer screening?
Well, I can start. This is Karen. I think that for us at the University of Chicago, it's been really helpful to have alignment with cancer center priorities. They have been able to put additional resources into spreading the word about colon cancer, and they've also been able to set up funds for investigators to be able to do research around prevention, which I think makes it much easier and allows us to disseminate this information in a much broader way.
This is Jenna, and yes, I am certainly affiliated with Markey Cancer Center, the cancer center we have here, and also I found importantly our clinical and translational center, CCTS, that we Center for Clinical and Translational Sciences. And they were able to help with having established community health workers at one of the emergency departments. We were able to tap into a resource that was already available in one of those structures to use as a trained community health worker. So I think we worked well with both CCTS and the Cancer Center.
Yes, we also have a relationship with the Cancer Center here at NYU, and we found that leveraging the mandate that cancer centers have to participate in community engagement is a way that basically everyone wins. And we found for those times when it's important to try to bridge patient navigators and community health workers between grants, that is a way that our cancer center has been very, very helpful in providing support.
Great. So many wonderful questions. Any other questions? No? Well, with that, I'd like to thank again our speakers, Dr. Ravenel, Dr. Hatcher, and Dr. Kim. I learned so much from all of you every time I hear you speak, so much appreciated. And Joe, if you don't mind advancing to the next slide, I think you've still got control. I just want to let everyone know that our next month, since it's March, we're not doing our monthly webinar, but we will be having a live broadcast geared towards the public about the importance of colorectal cancer screening. It's going to be awesome, a celebrity-filled event with Luke Perry, country singer Craig Campbell, and other celebrities, survivors, and of course, many of our expert friends within the roundtable speaking about the importance of screening. So it's a little bit later than usual for us. We're starting at 1 p.m. Pacific time, 4 p.m. Eastern. We'll be broadcasting from LA live from Smashbox Studio Theaters and our blue carpet. So I encourage you, all of you, to both join us and then also share with your network so we can get as many viewers as possible. And then the last bit of public service announcement is that to remind you that a follow-up survey will be coming around to all of you within the next day or two, as well as a replay of this webinar. So please do give us your feedback. That helps us continually improve. And with that, we will close out the webinar.